blooming hanging baskets this week at Bob Wine's. Bob Wine's Camellia Gardens, daily till 4, Saturdays till 3, in the same blooming place since 1952.
22 minutes after 10 o'clock. Thank you for tuning in. We probably all know somebody, maybe you are somebody who has had a hysterectomy. Dr. Magdi Milad is on the phone, and I hope I'm saying the doctor's name correctly. He is the chief of gynecology and gynecologic surgery at Northwestern Memorial Hospital, talking about alternatives to hysterectomies and the latest medical advances for women with chronic and painful gynecologic conditions. Dr. Magdi Milad, normally my co-host is a woman. Today it's two guys talking to you. So good morning. Thank you for talking to us today.
Are you there?
Thank you, Larry, and thank you, Joe. Thanks for having me on.
Oh, you're welcome. Where are you?
I'm in Chicago at Northwestern Memorial Hospital in the heart of the city.
That's where you are, okay.
So how far back were there alternatives to hysterectomies?
Oh, that's a great question. Yeah, I think there's been alternatives probably since the 70s. Maybe.
Really?
But I think we're getting better and better. Yeah, we're getting better and better at sort of how to strategize around creating a treatment plan for women. So, in the old days, and maybe even today, women would go to their gynecologist. They might have a symptom, and then, the gynecologist would recommend a hysterectomy kind of very early in the treatment options.
Mm-hmm.
Nowadays, we have centers where we can actually have a multidisciplinary approach. And a patient potentially can have like a one-stop shopping experience. Patient would come in, let's say, for fibroids, which is extraordinarily common. Before they even arrived at our door, they've already had their ultrasound, they've already had their MRI. They bring all those things in. We go over the images with the patient. We have them meet with a gynecologic surgeon. We have them meet with a doctor that can do hormones. We have them meet with a radiologist who can do interventional radiology procedures, so that they have multiple perspectives over the same condition.
Mm-hmm.
And then before they leave, they typically have a treatment plan that they can implement either locally here in Chicago or when they go back home.
And the treatment plan always includes hormones, right?
Not necessarily. Yeah, there's a long list of options now for fibroids or for pelvic pain and endometriosis, for example, that are often implemented. Yeah, so we really prioritize around what the patient wants. If a patient comes in and said, you know what, I really want to avoid hormones, you know what, we avoid hormones. Like, if it's reasonable, we avoid hormones.
Yeah, well,
if
because
says, I really want surgery, we avoid surgery. If a patient says, I don't want an IUD, I'd rather not think about that.
Oh, really?
The key is to prioritize what the patient wants.
Do you know, I think one of the things is in this world of communication and information, we are scared sometimes when we hear about certain things like hormonal therapy. I mean, we've had our share just doing a radio show. We've had our share of people who had not such good things to say about some of the hormonal therapy, and others who seem to think it's okay. So I think as the public at large, we become confused, especially when we're focused on something, and a lady going through a hysterectomy or the potential hysterectomy would be paying attention to that.
Yeah, no, for sure. The key is to sort of understand what the patient's fears and concerns and priorities are.
Mm-hmm.
So pain is a great example. Patients that come in with chronic pelvic pain, that it's interfering with their life, they can't be intimate, they can't exercise, they can't work, and they also have an interest, potentially in pregnancy. Like, the key is, what is the patient prioritizing? If she says, I want to get pregnant, I can live with this pain, then the treatment plan should be designed around pregnancy, like get her pregnant.
Mm-hmm.
And the success rate with IVF and so on in that type of a patient is upwards to 50%. 50% success rate first try in a patient that has endometriosis related to their infertility. In a patient who says, my priority is pain, I can't live this way. If I get pregnant, that's great, but that's not my priority. Then obviously we don't send them to fertility, right? We undergo a multidisciplinary approach using our physical therapists, our physical medicine doctor, our other options, hormonal therapies, non-hormonal therapies, to treat their pelvic pain.
Now,
might include surgery, might not.
well, let me ask you, when a patient comes into you and she's complaining about, how much of the plan is education? In other words, for you to educate them on the things that might be happening to them and all the possibilities. Is that a major part of it?
Oh yeah, we like to approach patients with this what's called shared medical decision making. So, the days of the doctor just saying what it is they're long gone. That just has no place for it. It's really like a collaborative effort with the patient in the middle of it to tell us what are their priorities, and educating them so that they can make the best decisions, because they're the ones that have to live with the consequences, right? It's not the doctor that has to live with the hysterectomy or the hormonal therapies. It's the patient. So the patient has to sort of have the buy-in and understand, like, what are the risks and potential benefits and complications of whatever intervention or the multiple interventions we oftentimes recommend.
Yeah, going back to Joe's question about the education part of this, if a woman does not know what to ask, I guess it depends on the doctor if they want to give them the other alternatives that are available.
Right. And I do see that. Like, believe it or not, in 2019, I'm still seeing patients. I'm their 18th opinion.
Wow.
They knew there was something else out there. They finally get to the person that can offer the entire list of therapies, and then give them their choice.
Okay.
So, we're still. I can't believe it. We're still seeing that. But yeah, absolutely. The patient should. And unfortunately, you have to educate yourself, and you also have to know that there's something else out there, and you also have to go to the expert. I mean, if you have one condition, you go to one type of doctor, and if you have another condition, you go to the expert for that condition.
Correct. Yeah.
So there are places in the country, all over the country, that that this is what they specialize in. Like, for me, this is all we do. All I do all day long is complex, benign gynecologic conditions. I don't do OB. I don't do pap smears. I don't do cancer. I don't do high risk obstetrics. Like, I do only this. Yeah. This is our center. This is all we do: is fibroids, endometriosis, pelvic pain, ovarian cysts, these types of complex conditions
Doctor,
in women.
I want to, not to be rude, but we have a clock that we're looking at, and I want to be sure that our listeners can find out the information that they need. Does the website that I have here, migs.nm.org, is that the one? Is that the best idea, best suggestion?
That's perfect. Yeah, that's great.
All right, well, we'll put that up. It's for Northwestern Medicine, I believe. Thank you, Doctor. Thank you for being on the show with us today. We'll be right back.
Larry, thank you, Joe.
And Trump welcomes the Polish president to the White House today, while the Democratic frontrunner continues stumping in Iowa this morning.
Joe Biden made 3 stops in Iowa yesterday, but he did not make it above the fold on the front page of the Des Moines Register.
Fox's Peter Doocy says President Trump got more coverage
the morning after he did something very surprising.